broadcast is now starting. All attendees are in listen-only mode.
Good morning to everybody on the West Coast, and good evening, afternoon to those on the East Coast. On behalf of the Fight Colorectal Cancer team, I'd like to welcome you to the webinar today, the research update, specifically on focused and research funding from the Fight Colorectal Cancer team around understanding more about early age onset in colorectal cancer. So we're going to go ahead and begin today with the broadcast. We have all of our presenters and team. So just a quick thank you to Dr. Christine Momenti, who I'll introduce formally in just a minute, who will be our featured presenter around some funding work, specifically looking at the prevalence of advanced adenoma and trying to better understand the role in early age onset, particularly for cancer survivors, and thinking about those who are diagnosed with advanced adenomas and thinking about the burden of disease as it relates. So we're super excited about the discussion. We'll also talk a little bit about early age onset and the overall phenomenon as well, and I'll introduce that. So just a quick reminder to everybody that scroll bar is over to the right. Go ahead and answer or ask any questions real time by keying in your specific questions into the chat, and at the end of the webinar, we will have Dr. Molmenti share her perspective on the work and her research. Follow us along on Twitter, and then also after the webinar, there will be materials shared as well as a short survey. And just a quick reminder that all Fight CRC webinars are archived on the Fight CRC site. And then this is just a close-up of the webinar chat feature. So again, questions we really want to focus on more broad, not anything specific about your direct medical diagnosis or the like. We'll try to get to many of those as possible, but we'll just go ahead and have you enter in these information, the questions through the actual control panel feature over on the right side of the screen. Just a quick reminder, Fight CRC has a bevy of resources, the award-winning Guide in the Fight, clinical trials, webinar, mini magazine that focuses on patient resources and different opportunities for patients, as well as our Tabubi podcast. And most of these are saved, of course, at the Fight CRC Fight CRC website, and are available for download for free. So please take advantage of all the great resources. And just as I noted previous, we want to make sure that this information today provided is for general education and for overall information sharing. We ask that you please connect with your physician and healthcare team related to your own medical needs. And of course, if there's ever any time that you have an emergent situation, using 911. So again, just general information and education, and make that connection with your team and bring this information, but we are not providing direct medical advice today. Next slide. So on behalf of the Fight Colorectal Cancer organization and team, I just want to say thanks for everybody for attending. I am going to be sharing a little bit of information about Fight CRC's work in early age onset, why we're committed to this cause, and just share, of course, that a lot of my passion and experience comes from the joint role at University of Colorado Cancer Center, the School of Public Health, and also because my family, we have definitely a history of colorectal cancer, and this is near and dear to my heart. Thank you for joining us. And also my guest presenter today will be Dr. Christine Momenti, who is an assistant professor of cancer epi at the Department of Occupational Med and Prevention in terms of the Northwell Health Center in the New York area. So Dr. Momenti has been very engaged in a lot of colorectal cancer research, epidemiologic studies, and she also wears many hats in terms of being a medical advisory board member for CCA, as well as holding a number of positions with the National Colorectal Roundtable and others. So she's been a driving force in the area of early age onset, and we are really excited to have her talking a little bit about the funding that Fight CRC provided to really help propel some of the research and hopefully understanding more about early age onset colorectal cancer. Next slide. So just a quick reminder that Fight Colorectal Cancer really has 4 dedicated themes and pillar areas. And today we're really going to be talking about the research component in terms of supporting research and really helping drive the research agenda. So I want to just remind everyone that Nancy Roach, many of the folks who are the founders of Fight CRC and the like, have really been dedicated towards moving policy and advocacy in this arena, as well as directly helping support convening and research. And we're continuing that legacy through Fight CRC, and that's really from the vantage point where we'll be sharing today. Next slide. So a quick note about early age onset colorectal cancer. I think that, over the last 5 to 10 years, a number of clinicians, investigators, survivors, the advocacy community have anecdotally noticed an upshot of number of people who are very young and those well below 50 years old being diagnosed with colorectal cancer. And a lot of this, I think the voices, I think the cry for help, I think the asking the medical community to really respond has been heard through the Fight CRC team and with collaborators and researchers. And I think that just a quick note that in 2014, we did see an analysis that they really actually pulled together a number of studies and looked at the SEER data to actually show that this wasn't just an anecdote, this wasn't just happenstance, that based on a number of studies and research, we're really definitely starting to see an upswing in data suggesting that this phenomenon was true. So much so that at the time, about 1 in 10 colon cancers would be diagnosed in people under age 50. And as we know, screening, population-based screening at that time started at 50 based on all screening guidelines. And that 1 in 4 rectal cancers would be diagnosed in people who are under 50 years old. And so this was about the time that I started with Fight Colorectal Cancer. And I remember feeling this urgency, and I think the organization feeling some urgency to really look into this phenomenon and thinking a bit further about how do we support patients from the patient education research side, as well as how do we help really drive the research initiative to better understand the why. And so I think that this was further substantiated even with data that came out of the NCI and the CRC incidence rates, really when we were seeing, again, the continuation of data suggesting the rise in the very young and the middle-aged adults who are still under age 50, seeing an upshot in screening or upshot in colorectal cancer diagnosis. And I think that what's really profound in both of these specific data sets from 2014 and 2017 is really looking at the burden, and a lot of the burden for early age disease being related to people who have rectal cancer. Next slide. So I share this slide just as a bit of further epi data to show ultimately what we're seeing in terms of seeing the suggestion of early age onset being epidemiologically a real phenomenon. And ultimately, still thinking about colorectal cancer still being the second most common type of cancer, third most leading, or excuse me, the most common cancer, third most leading type of cancer-related death, and that oscillates between second and third. And we were actually starting to see, this mortality for young people really starting to increase, as well as looking at the incidence. And if you look at between 1994 to 2014, we see an incidence rate 51% increase in that period of time in people who are under age 50, as well as a sharp increase in mortality. We actually started to see greater incidence in African Americans versus non-Hispanic whites. And then we actually were starting to look at the trends in the early age onset and noticing that about 75 to 90% of the occurrences for people who were under age 50 were still a little close to that 58-year mark, around 40 to 49. And then really trying to then understand that distribution of cancers in colon and rectum. And again, from a number of the data sources, whether it's the American Cancer Society, JAMA, the different data sets, we're really just seeing a profound impact. And that I think it's important to remember that colorectal cancer is still largely predominantly in people age 50, but we're just seeing these gains in the under 50 in ways that we hadn't previous. And we really wanted to think further about where we're going in future directions. Next slide. So I think one of the most profound findings, and I think one of the things that's happened is that with the American Cancer Society and others really examining guidelines for average risk population and thinking about where to start screening age, whether it's 50, whether it's 45, whether it's 40 years old. One of the biggest things that's come up in the findings recently is that based on SEER data, the age-specific incidence is about the same for a 45-year-old in 2015 as it was for a 50-year-old in 1993, about 30 per 100,000 folks. And so I think that one of the things that we've noticed is, next slide, in terms of looking at population-based screening, Fight CRC has been very engaged in working to understand how this data will help basically put into the modeling studies to help really explore population-based screening and when to begin screening. So much so that we were involved in conversations with Dr. Ann Zauber and the Erasmus team in the Netherlands to talk about the MISCAN model and using this new incidence data to help really share where we really look at the most benefit for screening the average population. So Fight CRC was very engaged in looking at this data, also noting that it wasn't just a blip on the radar. We've been watching over the last 5 years to know this isn't just a just a random phenomenon, that data is moving ahead, and really to show that there is a substantive need for maybe updating the guidelines and looking at the screening recommendations. But I think in addition to really thinking help informing the average risk population guidelines and understanding the role of family history and making patient education aims, one of the things that we've been really asking is why. I think that we're going to be focusing a lot of our research funding as well as the policy initiatives around the convening the researchers as well as partnerships to really drive better understanding of what are the types of cancer that we know. We have no idea why early age onset is happening in certain groups, but then also doing something for people that we know are at risk because of their certain type of family condition, certain types of polyp behavior and the like. So one of the things that we're going to be stressing and talking about today is a specific partnership with the Christine and with Heather Hampel, who Christine will introduce her whole study team. But one of the things that we have noted, and through our work with the National Colorectal Roundtable, as well as looking at these trends and then looking at better understanding of what's driving early age onset, is there's some key missing data in some specific areas that will help us make better decisions about research moving ahead. So we really want to focus a little bit today on the early age onset and thinking about advanced adenomas. And so this did develop out of the partnership, as I mentioned, but it's been an idea and a question that's been cultivated through the National Colorectal Roundtable and many research and experts like Christine who've been thinking about what are the missing data points and how to move this ahead. So we're really thrilled to talk in the name of collaboration and then with the funding that Fight CRC has to help hopefully answer one of those critical questions based on polyp behavior and what this means for the incidence and burden of disease as it relates to early age onset. So Christine, I'm going to pass it over to you and have you share a little bit about this work and what we think the contributions might be going forward. Okay, I just want to see, Sharon, can you hear Christine?
There. Can you hear me now?
Yes, very good.
Okay, perfect. Andi, as always, thank you for that wonderful introduction and for leading the charge. You do such an amazing job, and I really appreciate the opportunity to be here today to talk a little bit about our study. So thank you for that, and welcome to everyone to this short segment on our research grant that was just funded by Fight CRC. And the title of our grant is a feasibility study to determine history of advanced colorectal polyps among relatives of early onset colorectal cancer patients. I've modified the title a little bit. We were talking about advanced adenomas, but given our recent work with the National Colorectal Cancer Roundtable and the development of our GI brief, which is yet to be introduced, we want to really capture advanced adenomas, but all advanced polyps that may be one of these contributors in young onset colorectal cancer. So just as Andi was mentioning, I'm very passionate about colorectal cancer, mainly because it is such a largely preventable disease, yet it remains, I had the third most common and second leading cause of cancer-related death, but it sounds like the numbers are always changing, and again, it's just emphasizing how important this disease really is and the opportunity that there is for prevention. So let's see if I can advance here. Okay, there we go. So, so our collaboration for our Fight Colorectal Cancer grant is with the Feinstein Institute for Medical Research and Northwell Health, which is my institution. And my collaborator and co-PI is Heather Hampel from the Ohio State University Comprehensive Cancer Center. And this is a great example of a very effective collaboration that really came out of discussions between Dennis Anand from the University of Colorado, and he's one of the steering committee members of the National Colorectal Cancer Roundtable, and Heather Hampel. They were both discussing this idea. And this collaboration really arose from their conversations, and I'm just so pleased to be part of it. And so what we're trying to accomplish with our grant is really to understand one of the potential key factors associated with young onset colorectal cancer, and that is what is the prevalence of advanced polyps in the first-degree relatives of these young onset colorectal cancer patients. And I'll explain all of that as we move forward. But our study was initially funded to really see the feasibility and to understand, can we recruit the early age onset colorectal cancer patients, and can we recruit their family members? And so I'll talk more about that as we go forward. So I'll provide a short overview of what are advanced polyps, why are they significant, how are we defining young onset, how do we define first-degree relatives, and what is our research question? I'll tell you a little bit about our methods and our outcomes, and then our future projects and next steps stemming from this work. So a little bit about the introduction and rationale. So just to start on a very, to the very beginning of where we think about with colorectal cancer prevention, colonoscopy is one of the main and really considered the gold standard for decreasing incidence or new cases and mortality or deaths from colorectal cancer. The reason that colonoscopy is so important is because it can detect cancer at early stages when it's curable, and when the survival is really great. Over 90% is when we find colorectal cancer in its very earliest stages, the 5-year survival is over 90%. And when we find it in later stages, that can go all the way down to almost a 14% survival over 5 years. So detecting cancer and colorectal cancer early in its curable stage is important for prevention, but also colonoscopy can detect precancerous lesions or polyps. And when we detect cancer early and remove precancerous polyps, we can prevent colorectal cancer. And going back to our early statistics of preventing the third most common cancer and the second leading cause of death. When we talk about colorectal polyps, they're really categorized into two main types. There are serrated lesions, which account for about 30% of polyps that are removed. And within the serrated lesions, there's a number of different types. There's hyperplastic polyps, which are benign polyps, which mean they don't have any cancer potential. And those are frequently diagnosed in patients who undergo screening colonoscopy. The other types of serrated lesions include sessile serrated polyps and then traditional serrated adenomas, which are fairly rare. When we talk about sessile serrated polyps, sessile mean very flat polyps. Serrated, they have sort of a sawtooth or jagged edge. And again, these serrated lesions account for about 30% of polyps that are found on screening colonoscopy. A more common type of polyp are adenomas, and these are found in about 70% of people undergoing average risk individuals undergoing screening colonoscopy. I've seen estimates of upward of 70 to 85%, but we know that these adenomas are really responsible, the adenomatous polyp is really responsible for the majority of sporadic colorectal cancer, meaning colorectal cancers that aren't due to family history or inherited genetic mutations. They're quite common. About 30 to 40% of the population will develop an adenoma by the time they're 60. And if you've been diagnosed with an adenoma, 20 to 50% of those will recur in 3 to 5 years. There are a number of characteristics of adenomas. There are dysplasia, we call these high-grade or low-grade dysplastic polyps. And then there's another histological subtype called villus or villosity, and these are tubular, tubulovillous, and villus. The high-grade dysplasia and the villus architecture or villus features, and we'll talk about this more, really drive some of the advanced features of these polyps. But for the most part, the majority are very low-grade or tubular adenomas. The reason that polyps and adenomas and serrated lesions are so important is because they are on the path to colorectal carcinoma. And this is really a unique feature of colorectal cancer, and one of probably the benefits of studying colorectal cancer, because there is a target for prevention. We have an opportunity to detect these precancerous lesions that would otherwise go on to carcinoma. Colorectal cancer is a very slow-growing tumor, which over time, a number of genetic mutations and partly driven by the inflammatory response can actually drive the aberrant foci, which is the ACF, into an adenoma and then into a colorectal cancer. And as the polyp size increases, we see more advanced features within those polyps. So our diminutive polyps, which are very small polyps, these are less than 5 millimeter adenomas, and a lot of the adenomas that are found are actually in this very small stage, under or around 4 millimeters. As a diminutive polyp would get bigger to a small polyp, which is 8 millimeters, these become a little less prevalent, but you'll see as the polyp size increases, so does the malignant potential. And it's only once we get to the large polyp where we're seeing this is 20 millimeters, which is over a centimeter, we see that these are even less prevalent, but they have a higher percentage of the polyp that is actually malignant or has a greater cancer potential. And there are a number of factors that increase these risks for advanced polyps, and I'll talk to you a little bit about those in a second. But let me just first tell you what these categories of advanced polyps are. So they're any tubular adenoma that's greater than a centimeter in size, or has villous elements or this high-grade dysplasia. Any sessile serrated polyp over a centimeter in size, also with cytologic dysplasia. And then any traditional sessile adenoma, these were the ones that were pretty rare. And regardless of size, if a traditional sessile adenoma is found on colonoscopy, it's automatically considered an advanced polyp. So we really think about advanced polyps really with two characteristics, the size and the histology. If it's over a centimeter, we're talking about advanced polyps. If it has any dysplastic features, a high-grade dysplasia or cytologic dysplasia, we also automatically put that into an advanced polyp category. And so those are some of the key features that we look for. The reason that they're advanced is because, we call them advanced because it increases your risk for colorectal cancer in the future if one of these are found on colonoscopy. And there are a number of factors and risk factors that actually increase our risk for advanced adenomas and advanced serrated lesions. And these risk factors for serrated lesions are associated with increasing age. Also, smoking appears to be an important risk factor. And when we talk about adenomas, there's actually advanced adenomas, I should say, there are a lot of overlapping risk factors with colorectal cancer, things like obesity, cigarette smoking, heavy alcohol use, or alcohol use, any amount of alcohol can actually is associated with a large number of cancers. Red and processed meat consumption, sedentary behavior, being male, increasing age, and having diabetes are also associated with advanced polyps and advanced adenomas in particular. So those are some of the risk factors that are associated with these advanced polyps. And the reason that they're so important, and what we're going to be talking about here, is that we don't know some of the causative factors of young onset colorectal cancer. And our hypothesis is that maybe some of these young cases had family members with advanced adenomas, and they should have been screened earlier. And I'll talk to you more about those screening guidelines in a minute. In our particular study, we are talking about young onset colorectal cancer cases, and we're defining them as individuals diagnosed under 50 years of age. In the literature, adolescent and young adults are generally defined as 19 to 39 years of age. And we do see literature for young onset colorectal cancer that looks at individuals under 30, under 40, but we're actually looking at the under 50 population in general for this study. And just to emphasize what Andi had mentioned earlier, the trend in young adult cancer in this 20 to 29-year-old age group in particular, which has been increasing at a rate of 3.8% annually since 1987, is really problematic, and we're hoping that we can make a difference in that area. And we also know that in this younger group, in the 20 to 34-year-old age group, the predicted incident rate of colorectal cancer is predicted to increase by 90% by 2030. That's for colon cancer, and rectal cancer is predicted to increase by 124% by 2030. So again, just emphasizing the urgency to really understand, you know, the reasons why this is occurring and how we might be able to prevent these cases. In our study, we are specifically interested in first-degree relatives. First-degree relatives are defined as parents, siblings, or children. And we know that there is an increased risk of increased colorectal cancer risk among first-degree relatives of patients with advanced polyps. And so we know that there's an estimated, or there's up to 10% of US adults that have a first-degree relative diagnosed with colorectal cancer. And for the most part, people generally know that if you have a family member with colorectal cancer, you need to be screened early yourself. But what's not really known and what's not communicated as frequently is when you have a family member, a first-degree relative, a parent, sibling, or child that's diagnosed with an advanced polyp, you also need to be screened early. And that information doesn't get out as often as it should. And the reason that information is important is because first-degree relatives of patients who have an advanced adenoma diagnosed at time of colonoscopy, they have a 4 to 6-fold increased risk of being diagnosed with an advanced polyp themselves, and they have a 2 to 4-fold increased risk of developing colorectal cancer. And this is regardless of the age at diagnosis of the affected relative. So no matter what age your relative is, if they're diagnosed with an advanced polyp, their first-degree relatives need to know, because there are screening recommendations that indicate they should be screened earlier. And the two major gastroenterology societies, the US MSTF, the United States Multi-Society Task Force, and the National Comprehensive Cancer Network, NCCN, has come out with guidelines for first-degree relatives of patients who've been diagnosed with advanced polyps. And we've summarized this in some other documents, and I just, have provided the guidelines here, but just in general, if a patient is diagnosed with an advanced polyp, the patient's first-degree relatives should start colorectal cancer screening at age 40 or at the age of diagnosis of the advanced polyp, whichever is earlier. And if the patient on the other side has one or more first-degree relatives within a documented advanced polyp, the patient should start screening at age 40 or at the age of diagnosis of the advanced polyp in the first-degree relative, whichever is earlier. So it's really important that this news gets out to patients and that GIs are talking to their patients about this after screening colonoscopy or surveillance colonoscopy. So our research question for our study is, what is the prevalence of advanced adenomas or advanced polyps among early onset colorectal cancer cases? And our first step of our study is really to understand the feasibility. Can we contact these early onset cancer patients? Like I said before, those are people who are under 50 diagnosed with colorectal cancer. Can we contact their relatives to find out if their relatives had a colonoscopy, and if they have, what was their diagnosis? And then can we get those colonoscopy reports? And so this is what our first study is really aiming to determine, is can we actually conduct the study? And once we can determine that we can conduct the study, we'll then go back and say, let's answer the question of what is the prevalence of these advanced polyps in the relatives of these early onset patients, and be able to do that in a larger population. So the way that we're going to conduct this study is as follows. First of all, we have a very unique opportunity to study this population in a population-based cohort that was developed by The Ohio State University, and Heather Hampel who is one of the PIs of our study here, is the PI of the Ohio Colorectal Cancer Prevention Initiative, which ran between 2013 and 2016 in the state of Ohio. It is a massive research infrastructure developed by the Ohio State University Comprehensive Cancer Center. And they accrued patients all over the state of Ohio in this 3-year period. And they identified in this particular population 492 cases of colorectal cancer under the age of 50 that had no known susceptibility, genetic susceptibility to colorectal cancer, and no known family history of colorectal cancer. And Heather, Dr. Hampel was the PI of one arm of the study, which was the Universal Screening for Lynch Syndrome study. And Electra Pasquette was the PI of the Adherence to Colorectal Cancer Screening arm of this study as well. And so we have a unique opportunity to accrue patients that were already enrolled in this trial. And Heather and I will be working on this together to set up the entire Fight CRC study that we've been funded for. And so this is what we're aiming to really achieve in this study. So this is the, this whole pie chart here is the Ohio Colorectal Cancer Prevention Initiative. And this pie here that we have is the Universal Screening for Lynch Syndrome study arm, which, as I mentioned, Heather Hampel was the PI of. And among those 709 patients, she found that through multi-gene panel testing, 16% had a hereditary mutation or had a genetic susceptibility to colorectal cancer. She also found that another 14% had a family history of colorectal cancer. So about 30% of that population has sort of been accounted for. We know they either have a genetic mutation for CRC or they have a family history. What we're trying to determine now is what percentage of these patients who are otherwise sporadic have a family history of advanced adenomas or advanced polyps. And if we can determine that number, we don't know if it's 14%, is it 20%, is it 30%, or another percentage. That may help us understand what percentage of sporadic young onset colorectal cancer is really due to one of these three things, either hereditary predisposition, family history of colorectal cancer, or a family history of advanced polyps. And then maybe that actually lessens the amount of the pie that is unexplained. Because right now, pretty much we only know that 30% are due to these other two factors, and there's 70% that is unknown. If we can figure out what piece of the pie is due to this family history of advanced polyps, then we have a lesser percentage to really determine, what are some of these other factors and what is the why for these sporadic cases. So our study in just a little more detail will include 492 early onset colorectal cancer patients. And of those 492, we're going to randomly select 50 who will be enrolled in our feasibility study. Again, these are patients diagnosed between 2013 and 2016. They were diagnosed with primary invasive colorectal cancer adenocarcinoma under 50 years of age. They were not identified as having a cancer susceptibility gene or having a family history of colorectal cancer. So what we're planning to do is contact 50 people and their first-degree relatives. We anticipate each patient, or we call these probands, that are the index case of the young onset cancer. We anticipate that each of them will have approximately 4 first-degree relatives, meaning maybe 2 parents, 1 sibling, or 1 child, or maybe 2 siblings. Remember, these are cases under 50. So some of them might have younger children, some of them may have a little bit older children, but all in all, we anticipate we'll contact about 200 first-degree relatives from these initial 50 probands. So there's 4 phases of our study. The first is to contact the cases. Once we contact the cases and get their first-degree relative contact information, then we'll contact their relatives. Once we contact the relatives, we'll get the colonoscopy reports of the relatives, and then we'll do our analysis. And we have a pretty big team assembled to help us conduct and execute our study. So on the left is the Northwell Health study team, which includes myself, Andrea Zimmern, and John Ritchie. Both of them are colorectal cancer surgeons in our health center. And Heather Hampel, who's the PI at her site, will also include Electra Pasquette as co-investigators and Rachel Perlman, who again is one of the genetic counselors in her program. And then we have a number of other staff members who will be assisting us in all 4 phases of the study. On the left, we have 4 general surgery residents in GI at Northwell Health, in addition to a surgery fellow, Alyssa Bianchi. Her picture is below, or isn't below, but she's below Dr. Gurian. And then Gina Arena, who is a very important member of our group. She's our project coordinator, helping us with all aspects of our study. And then on Heather's team, she has a program director, a program manager, a clinical research assistant, and a student research intern. And this entire team will help us reach out to the probands, the first-degree relatives, and the colonoscopy facilities to collect the colonoscopy reports. So a little bit more about our study flow. Our phase 1 of the study is contacting and consenting the probands. And the probands who will be eligible for this study, like I mentioned, are those who are pretty much considered sporadic cases of colorectal cancer because they have no known family history of colorectal cancer and they don't have a mutation. We're going to contact these patients by sending them letters. For those that we have emails, we will send emails. The letter will be addressed by both the Feinstein Institute for Medical Research and the Ohio State University. We're very sensitive to the fact that these patients were initially enrolled in Ohio through the Ohio Colorectal Cancer Prevention Initiative. And so we want to be sensitive to recontacting them for future studies. All patients who will be recontacted did note that they would like to participate in future trials. So we're only going to be contacting those patients who said they would like to be contacted in the future. The data collected in phase 1, really, their only commitment to our study is to provide the contact information for their first-degree relatives. So we want to know if we can contact their parents, any siblings, and children. In phase 2, we'll be contacting all the FDRs that we collected in phase 1. We think there'll be about 200, maybe 250. Again, we'll be reaching out to them with letters, with emails, and asking them if they want to participate. I should have mentioned in phase 1, we have 492 patients to start with, and we're going to be doing sort of a rolling enrollment until we get our 50 consented for our feasibility study. So in phase 2, we'll have our first-degree relative contact information. We'll reach out to them with letter and emails. And then in phase 2, our data collected will be colonoscopy information. We'll be asking them for their physician that conducted their colonoscopy, the facility where it was conducted. And then in phase 3, this is where we will really be working with our GI fellows and residents who have agreed to be the point people for contacting the facilities, getting the medical release form signed from the patients, and collecting all the medical records related to colonoscopy for those patients. So the data collected in phase 3 are colonoscopy records, and we'll be looking on those colorectal colonoscopy records for advanced polyps. How many of these FDRs had advanced polyps removed? So some of our study outcomes include, and again, this is a feasibility study, so we're trying to understand what is the recruitment rate of probands? What is the number enrolled in the study divided by the number of people we approached? So was it easy to get people screened and consented, or is that percentage fairly low? The recruitment rate of FDRs, same thing. How many FDRs did we have to approach to get, 50 enrolled or 250 enrolled? And these numbers will be important for our larger study because it'll help us understand, how many people we need to contact, what type of staffing that we need, and what is the feasibility of conducting that study. The third feasibility outcome is the rate of medical record verification. So were we able to collect colonoscopy records, and how accurate was that information, and how many endoscopy clinics did we have to contact that were provided by the first-degree relatives? We're also looking at additional feasibility estimates related to the average length of time to obtain EMR records, the medical records. So if the average length of time needed to obtain colonoscopy and pathology records is 1 month versus 1 year, this is going to be very important for us planning a large-scale study. The accuracy of self-reported colonoscopy results. One of the things that we're just going to measure on the side is we're going to ask the first-degree relatives if they remember what they had removed at time of colonoscopy. And then once we get their colonoscopy records, then we will look and sort of match what they said versus what the medical record reported to see how accurate self-report is for colonoscopy results. The reason that this is important is because in the future, in a larger trial, if we have to rely on self-report, if we're unable to contact the facility, if the person can't remember what colonoscopy facility they had their colonoscopy performed at, we will have to rely on self-report, and we'd like to know on average or as an estimate how accurate is that. And then lastly, we'd also like to know the reasons that the probans or the early onset cases and the FDRs refuse participation. So we'd like to know what are some of the barriers to participation in this type of study, and what are some of the facilitators to participation. So this will allow us to employ strategies to improve response rates in a large-scale study as well, if we can address some of these particular factors. So our future study and next steps include the following. So we want to include or conduct a larger future study to accurately estimate the prevalence of advanced polyps among first-degree relatives in a larger early onset cohort. So we're starting with 50 for our feasibility study, but we have a cohort of 492. So the idea is, can we, in the future, look to this larger population of 492, and we've done some power estimates to see how many people we'd need to recruit and enroll. And we think that we have the population to do so once we can enroll a larger number to really get an accurate number of the prevalence of advanced polyps among first-degree relatives of this young onset cohort. But research initiatives are also needed to fully explore how do we reach family members of individuals diagnosed with advanced polyps and adenomas. So if someone has a colonoscopy and the GI tells them that they had an advanced polyp and they need to tell their family members to be screened earlier, there needs to be some additional reinforcement, resources, and tools to help those patients talk to their family members. What information can we provide them with that'll help them have that conversation? And there's very limited knowledge and research in this area so far, so this is a very important research gap. When we do the larger scale prevalence study, these are the outcomes that we're looking for. One is, what is the prevalence of advanced polyps among first-degree relatives of early onset patients who are otherwise sporadic, meaning they don't have a hereditary syndrome or a first-degree relative with colorectal cancer. We also want to know what proportion of early onset colorectal cancer patients would have been recommended to start colonoscopy prior to the age at which they developed colorectal cancer. This would have been really important. So if a person should have been screened at 40 and they were diagnosed with colorectal cancer at 45 or 47, a proportion of those patients could have been prevented potentially. And that is our third future outcome, which is, what is the proportion of patients that were diagnosed with young onset colorectal cancer that could have been realistically prevented or detected early? The impact of this research, there's so many important public health implications and clinical implications just by raising awareness among gastroenterologists and primary care physicians about young onset colorectal cancer. They're at the front lines clinically and have contact with patients and are there and often are the first ones to see many of the early symptoms and signs of young onset cancer. So raising awareness among GIs and primary care is essential, and also improving communication of polyp findings, not only for the patient, but to patients and their family members in order to promote and ensure uptake of adequate and early screening guidelines. So a couple take-home messages are on just a sort of a general level. Know your family history of colorectal cancer and colorectal polyps, particularly advanced polyps, and talk to your close family members so that they understand your colonoscopy findings and that you understand their findings as well. It's a two-way street and back and forth. Talk to your gastroenterologist to determine if early and more frequent screening is recommended for you. those are the two main take-homes, and sort of really sort of the actionable items that you can take and implement from this talk. And if you have questions regarding any of the research topics that I discussed, or the methods or our approach, I'd be happy to answer any questions. And you can also reach me here at my email at cmolmenti@northwell.edu. Thank you very much.
Thank you so much, Dr. Momenti. We do have some questions that came through, so let me go ahead and pull those up. Okay. All right, so our first question is, what do you recommend people do if they do not know their family history? For example, people who were adopted.
That is an excellent question. Family history is such an important component. If you don't know your family history and you have been adopted, one of the things that you can do, because genetic testing is so common today, I would say the first thing that you could probably do is try to rule out any potential inherited mutations for colorectal cancer. And that would include Lynch syndrome, which is the hereditary non-polyposis colorectal cancer, Hnpcc. The other inherited syndrome is FAP, familial adenomatous polyposis. So if you could consult with a genetic counselor, have genetic testing, and determine if you have any of those inherited genetic mutations, that is probably your first step. Understanding your family history of colorectal cancer and advanced polyps is difficult. Obviously, being adopted, you wouldn't have access to that information. But I'll tell you, for even the general population, for those people who are not adopted and are close or know of their blood relatives, the advanced adenoma communication is really tough, because we conducted a pilot study and we found among people who had colonoscopy, we interviewed 100 people who had a colonoscopy in the last year, and we asked them what they had removed, and then we looked at their medical record to verify how accurate their reporting was. And we found out that about 88% of people who had advanced polyps removed didn't know they even had an advanced polyp removed. They didn't know what type of polyp was removed. Many of them didn't even know that they had to be screened early themselves, or had more frequent surveillance. So family history is something that the National Colorectal Cancer is really working on, the American Cancer Society is working on, and there will be more tools and resources available moving forward that you can access. But even so, when people access these materials and understand their family history, the data is really showing that even screening rates among individuals who have a known family history of colorectal cancer, half of those individuals are adherent to screening guidelines. So there's a lot of work that needs to be done on a behavioral standpoint. How can we change people's behavior to be screened early once they know of their family history? And then, the starting point, which is what you've mentioned as the question, is how do we really get that communication, that flow of communication going between patients and their families? But it really has to stem from the medical provider. Primary care and GI really have to encourage that conversation. So I hope, is that helpful? If you have a follow-up question,
yeah,
please.
Absolutely. We had another question that came through that I think this also answered around, what's the best way to get message out to patients to get this information and share it with their first degree relatives. So it sounds like starting, with the primary care or the physicians, the healthcare professional, really talking to the doctor, to the patients, and then the patients then talking to their families. So it sounds like a lot of education.
It's a lot of education, a lot of awareness, and I think the reason that this grant is, one of the reasons it's so important is, if anything else, it's going to raise awareness of this issue. And because young onset colorectal cancer, as far as the sporadic cases go, is so largely unknown. If we can just figure out a piece of the pie that is due to advanced polyps in their family members, I think is going to be a big step forward. And from an awareness standpoint, I think it's a great starting point and a great jumping off point for future work.
So another question we have that just came through, do you have planned interventions if the response rate to the contact attempt is low?
If from the proband or the FDR?
I believe she was referring to the FDR, I think. So let's see if she has a follow-up.
Okay. Well, so there are two steps, and there's two places in our study that we could really potentially run into an issue, which is is there an issue with the probands, and is there an issue in recruiting the FDRs? Some of the ways that we will address the proband issue is beyond the letters and emails, which is our main and our first point of contact with them. We have 492 patients, as I mentioned, to recruit 50. So we're hoping that as we do rolling enrollment, we will eventually get to our 50. I think that one of the key strategies in that first phase with probands is really engaging the Ohio State research assistants and research staff. Some of them were involved in the recruitment of these patients to the original study. And so I think having that personal contact is going to be a key piece for recruitment with the probands. With the FDRs, now this will be a brand new sample of people that haven't been contacted for a previous study. And again, with the first-degree relatives, this is going to be and this is why we need to do feasibility first, because some of the first-degree relatives of the probands may be individuals who are not even close with anymore, or maybe they don't want them to know their personal information. There could be a number of different barriers that we run into. But I think that as we go forward and determine some of the barriers, which is one of our potential outcomes, we may be able to sort of adjust and move forward once we determine what are some of the reasons why people don't want to join the study. And that is a data point that we will be collecting, which is if they do decline, we will ask them, what are some of the reasons why you don't want to participate? And then maybe we can adjust and correct from there based upon some of those reasons that we uncover.
Great, thank you. We do have a couple more questions. Should everyone begin screening at age 45 based on ACS updated recommendations?
So the screening at age 45 may be important for a number of people. Currently, we are still trying to generate enough empirical evidence to really change the guidelines to age 45. For people that are between 45 and 50, insurance and coverage of colonoscopy can be an issue. So I think all of that has to be taken into account. For anyone with a family history, absolutely should be screened at 40 or earlier, depending on the age and diagnosis of their relative. I think that we may start to find more people who realize that they have first-degree relatives with advanced polyps that may want to be screened earlier. And so that particular population, I would say, if you haven't been screened and you're 45, then that would be an appropriate population for that group between 45 and 50 before the actual, the current screening guidelines kick in, which is at 50. For any African American individual, the screening guidelines are at age 45 currently. So that population is currently recommended to screen. But again, we are really trying to, understand and bring forward the empirical evidence to make a case for screening and for changing the guidelines to 45 in general.
And as a follow-up question, you mentioned family history. Are people still at a heightened risk with a second-degree relative having been diagnosed with colorectal cancer, for example, cousins, grandparents?
Yes, so for a second-degree relative for colorectal cancer, and even in the advanced polyps in my previous slide, the recommendations, depending on the age of the person or the index case that has the cancer or the polyp, the early screening may apply. So if it's under 60 versus over 60, and the number of second-degree relatives also changes whether a person should be screened earlier or not. So if someone has more than one second-degree relative or two or more, then the screening recommendations are adjusted appropriately. So for anyone with a second-degree relative, you need to check the guidelines. There are screening implications, but again, it really depends on the age at which those second-degree relatives were diagnosed, and it depends on the number of second-degree relatives that were diagnosed.
Great, thank you. And of course, talking to your doctor about your risk, the Fight CRC website has all that information about screening and the updated guidelines as well.
Yes.
And our final question here, if first-degree relatives have passed away, is there a way to obtain their medical records for this?
That's an excellent question. I didn't mention this. So what we're planning to do with all of the 492 young onset cases that were collected, each of them has emergency contact information for their next of kin information. So we will be contacting those relatives or those emergency contacts that are listed. And we're going to try to piece together the first-degree relative information from that contact. And we'll be asking them, who are if they have the names and contact for their parents, for the patient's siblings, for their children. And there is a portion of these young onset cases that are deceased. So we're actively preparing for contacting those that have next of kin or emergency contact information.
Okay, awesome. Well, thank you so much, Dr. Momenti, and of course, Andi Dwyer from Fight CRC. That wraps us up for the day. What exciting research. We're really looking forward to following along and getting the updates when they're ready. So thank you so
very
much.
Thanks so much.